I just want to give a little pitch about my organization, and it's always good to do that. But I try to give you the context of my organization, look a little bit about FGM in the UK, and some of our community engagement strategies. Share a little bit about the peer research we've been doing in the community, and a little bit about the programs, particularly Women's Health and Leadership, and our Young People Speak Out program, as well as sharing some of the lessons. We are an African diaspora-led organization, and primarily aiming to work towards safeguarding rights of African women and girls. We operate in the UK primarily, but we have found it also necessary to operate in parts of Africa, particularly because we feel as a diaspora-led organization, we also have some learning and some sharing to do with our sisters and back in Africa. Our areas primarily is on tackling female genital mutilation, but we also look at child marriages. In the UK, there's a big focus now on forced marriages. And we feel child marriages is a subset of forced marriages, but most of our work on child marriage is actually really in Africa, and looking at some of the related health problems. Our vision is that women and girls really live in dignity, are healthy, have choices, and equal opportunities to really fulfill their potential. And as a result of that, we work in the area of public education and training, policy advocacy and campaigns, because I think it's important to engage at a range of levels. Provide program support and particularly some advice and services. We provide services such as resources and to generate the evidence to support public education and also policy making. And I think one of the things that we have really put some energies in recently is promoting women's empowerment and women's voice, such that their voices come out in policy making, but also at the local level. In terms of the context of our UK work, we've been instrumental as Forward to provide information on prevalence studies, and we always have, there isn't any evidence. FGM doesn't happen here. Well, it's something that is happening in Africa, and we don't really think it happens here. Does it really happen here? Where is the evidence? And I tell myself that the evidence is really right in the hospitals, and you can always collect the information and you can always use it. But that information isn't used. That information isn't even collected. So really, in terms of where is the data, we are a charity. We have to search for money before we work. And sometimes we don't even get money from the government. Although it's very nice sometimes when you hear the parliamentarians are put to up, I ask questions. There's always support Forward. Well, they used to give us $30,000 a year. So that's about supporting Forward. So again, some of these issues are really, really interesting. But at the end of the day, we really need data. And how do we get the data? And what we did with the data was we used 2001 census. We've just had a census in the UK just last month. And we do hope that that would give them new information. And through that data, we extrapolated prevalence rates back in Africa and looked at the countries of origin from the statistics. And as a result of that, we then managed to get some extrapolated data in terms of numbers in the UK. That's clearly underestimated because we didn't focus on people who were born in the UK. We only looked at people who were born outside the UK. In terms of information on children, we looked at births to children and used registration data. And what we found was that 24,000 girls were at high risk of FGM type 3, which meant that the mothers were from countries that practiced FGM type 3. When we looked at the total number of girls who were at risk from that data, it amounted to about 100,000 girls. But we almost always use the 24,000 as the figure. In terms of services, Forward extrapolated some data and asked questions from the 16 specialist clinics. And what we have here is data from 5 clinics alone, and that was in 2008. And it showed that 2,500 women between the ages of 10 to 50 had accessed some form of specialist service. So that gave us some idea of numbers, and this was in London alone. In terms of communities at risk, this is an overview of the countries. Now, you'll find that Kenya comes up top. But you'll also find that quite a number of Somalis came through Kenya. And we also have Somalis who are Kenyan origin. So you'll find that we do have quite a large number of Somali communities from FGM practicing communities. But we also have countries like Nigeria, and you'll find that there are some countries that almost always is seen that is all a Horn of African problem. So you're looking at Somalia, we're looking at Ethiopia, Eritrea, and not necessarily Sudan, and not necessarily looking at West Africa. But West Africa also comes up. And again, in UK, we also have Egypt. So these are the countries that are at high risk, particularly in the UK from the data. Talking of new developments in the UK, we are finding that now there is a gradual acceptance that FGM happens among Kurdish communities. And so we are finding some people from Kurdish communities talking about FGM. And we've started some partnerships, particularly on this area. And again, that gives very interesting discussions. Within Forward, we've had emails even from the Dawoodi Bora Muslim communities. We had an email where a woman said she was writing to inform us that it was happening in the UK. And she was a member of the Dawoodi Bora Muslim community, primarily Asian. And she said, I can tell you that most of the people from this community who practice FGM are highly educated, doctors, lawyers, but they are practicing FGM and in the UK. And then foolishly, I actually sent her an email and I said, very interesting. I think we need to link up and see how we can link up to the police. That was the end of it. I never had any further communication from her. And each time I sent an email, it just bounced back. The email had been erased. So clearly, she wasn't in a position to talk each time I had made the mistake of talking about the police. And so there is also other communities that are very silent, and particularly in the UK. But FGM is seen primarily in the UK as an African issue. We have local authority coming up, and some of them have specialist clinics. Some are setting up FGM steering groups, creating a forum and a network to talk about this at the local level. At the national level, there is an FGM forum, and I'll talk a little bit about that when I'm looking at the policy work tomorrow. In North London, there's also a community network which is set up, which is looking also at sharing information. But one very exciting thing for us in the UK is the establishment of a new initiative, which is the Special Initiative on FGM, which is funded by 3 trusts and foundations, Esme Fairbairn, Trust for London, used to be called City Parochial, and Rosa Trust. And they have funded 15 organizations. It's a 3-year initiative, I think, to a tune of 1 million. And the whole idea is to engage communities so that they can talk about these issues and have more focused work, particularly at the community level. Because to be honest, in the UK, the focus has primarily been on the statutory agencies. How do we ensure that we stop FGM but work with doctors, work with nurses, and work with social services? But why do we have to work with communities? We don't have to work with communities because we have legislation. We have policies, and that should do about working with communities. So when you ask anybody how to engage communities, they're very silent on that. He said, oh, but that's for the charities to do. That's for the community-based organizations to do. Our work is not to work at the community level. Our work is not to engage communities. Our work is to ensure that we provide the services. So again, it's very interesting when it comes to, and I remember I was in a conference in Birmingham, and it was very exciting for me because one of the agendas said, we're going to look at working with communities. And then when I saw the person speaking at the community level, she was a school liaison officer. The other one was a nurse working in a specialist hospital. And I said, clearly, you don't have communities here, so you don't have any community-based organization to work with. So again, that's the kind of environment that we're in when it comes to engaging communities. Our approach, particularly engaging communities, is very much because we want to have a shift really in community understanding and awareness. The fact that somebody comes from a practicing community does not necessarily mean that they are very okay with everything about FGM. So how do we shift understanding? And it was very interesting for us. One of the women that we started working with, we met and I spoke to her about FGM. And she said, Nana, come on, FGM doesn't happen here. Even from my the time we were coming from my country of origin, we had started a lot of public education and awareness things around FGM. So we've stopped. We're no longer doing it. I said, you may have stopped. It doesn't mean everybody has stopped. So again, people are not even aware of what their neighbor is doing because they don't talk about these issues. So we need to have a kind of more critical mass around understanding. Shift in social norms around FGM to say that it's not okay to do FGM, and that it's not necessary that FGM will stop a woman, like what you're saying. It doesn't stop a girl from being raped. And it's very interesting too, sometimes you have a few issues that really dispel some of these myths. We had a case where 2 girls were raped, and they were raped anally, actually. And when it was reported to the police, they actually realized that those girls had FGM type 3. So clearly, this goes back to the community and said, if they had not had FGM, they would have been vaginally raped. So it's good to have FGM. So again, these are some of the messages that's coming to the community. So it's quite interesting that situations actually revert communities to think that, well, it's best to also have FGM. We want to have a shift in engagement and to really invest in engagement, because I think we need to shift the dynamics from just talking to statutory agencies and policymakers to really give women at the community level a chance to engage in these issues. We also want to have a shift in policy, and to date, I haven't really seen any policy on community engagement. Every policy is about everything else apart from community engagement, and I think we need the dynamics around policy to shape our work in community engagement. And how do we engage young people? And I think that's one of the missing elements, and that's one of our strengths that we want to sort of look at. We also want to create the evidence base. And again, it's very good that all of us here have really been looking at the evidence, and also to invest in capacity of partners, particularly if we have to work with community-based organizations who are really, really all very much grounded in issues around basics. How do I fill this form? How do I access this information? My benefits, how do I, get all these issues sorted out? My son is in a gang, and my son really is giving me a headache. How do I deal with these issues? So those are the things that they are interested in. FGM is not really a big deal, and it's been said over and over again. So how do we invest in partners who can also look at all these issues, but also address some of these things? The evidence from our community work, and I'll share a little bit, we did this in-depth study, primarily in 3 cities, and the idea was to gain a better understanding of women's perceptions of FGM, what the practice really was in terms of its continuation in the UK, women experiences and perceptions around interacting with services, but also what do women feel about the practice for themselves and their daughters. We did it with technical support from an organization called Options Consultancy. And the whole process was also very empowering for us as an organization, because it also helped us to learn the process. And as a result of that, we've now replicated it in Tanzania, Sierra Leone, and Liberia. And I feel that this is a very positive way of moving forward and gaining information. It's a peer approach, and the methodology really requires that it generates stories, opinions, beliefs, and things generally about trends in the community. And we find that it involves particularly those who are concerned. So you engage the people from the community, you recruit them as the researchers themselves, but you also recruit them as supervisors, such that they get grounded in the work. And you also work with them to define the problem, to also identify the questions that need to be asked. And I remember when we did this study in Sierra Leone, one young girl came and she said when she was chosen to come and do it, she said, "Me heart caught," and she mean that she actually got frightened, how would she be called to come and do such a research? And we had a similar thing among the women we worked with in London. How can I be a researcher? I've never done research. I don't know how to do it. It's people who are in universities who do these kinds of things. I really can't do this kind of research. So it was really empowering for these women when we engaged them in this research. And so 50 women and young people were recruited as peer researchers, were from Eritrea, Sudan, and Somalia. We trained them during the workshops, which was more or less 3 or 4 days, depending on the setting, to do in-depth interviews. How do you interview people, the difference between open-ended and closed-ended questions. How do you engage people? How do you also, how do you identify questions that you need to ask? And we worked with them to develop the questions. And so it really was very meaningful for the community in terms of the information that we got. So I'll share with you a little bit of it, and these are snapshots of it. And one of the things was circumcision. Who really decides? You know, within the UK, who really decides? And mothers said they were under huge pressure, not only from all the relatives in the UK, but those also who were back home. Now, everything is very close. You have telephones and you have everything to communicate so easily. Relatives are coming in and out, and so they're more likely to put pressure on you. So you find that those who live in homes with older relatives are more at risk of having their children to undergo FGM than those who live in a nuclear family. They said they also fear the relatives who circumcise their children back home. And so when they go on holidays, daughters are kept under close supervision. There was even a sheikh that we spoke to, and he said, you know, even when I go home, I don't want my daughters to be done. I actually physically hold them wherever I go, and I don't leave them in the presence of relatives because they can choose to make the decision on my behalf. So again, it's very important, some of the dynamics there. And one of the interesting things that was also said is that mothers who were highly motivated and assertive were more likely to protect their daughters because they could make the decisions around that. And one story that was said, which I found amazing, was a woman who went to, I think I'm not sure which country, but she went with her daughter. And when she went, her mother-in-law said, well, it's time to have FGM, and we need to go and see the doctor. She said, no problem. When you're ready, I'll let you know. I'll have to go and approach the doctor because I don't want the traditional cutter to do it. I'll go with her to the hospital. So she approached the doctor and told the doctor everything and said, my mother-in-law is going to follow me. And when she comes in, make sure that she doesn't come into the surgery, and I'll go there alone with my daughter. And I want you to fake the FGM and make sure that she doesn't go through it. So everything went fine till they came out. And then the young child said, oh, nothing happened. So again, the mother was very quick and said, actually, she was put under anesthetic, so she really didn't know what was happening, and we stayed there for a long time, so she really has no clue about what was happening. But this was a woman who was really ready and wanted to protect her daughter at all costs. So sharing some of these stories was actually very empowering for the women. Again, FGM was seen as a women's business. We've actually said that a lot of times, but there were some women who said it was their fathers who insisted that they went through FGM. So again, I mean, we shouldn't let the fathers out of it totally because some of them are really behind it. And a lot of times it's the fathers who pay for the airfare, it's the fathers who make sure that they call back home. So the fathers have a stake in and they know what is really happening. So sometimes they give the impression that they don't know, but they did know. In fact, we had one girl who said she had just seen a young man who had taken his mother-in-law, his daughter, and his mother to the airport. And she put it bluntly to him, do you know that they're going to have FGM? And his face changed. And he said, surely you knew about it and you didn't discuss it. She said, we didn't discuss it. She said, well, the fact that you didn't discuss it doesn't mean it's not going to happen. So again, there are issues around silence of fathers. There was also the fact that women who decide not to circumcise their daughters, what will they do when they go back home? I mean, how do they fit in? A lot of women know that we're only here temporarily. What's the effect when we go home and we realize that your daughter hasn't been done? So again, we're finding that quite a number of families are faking their daughters' FGM to avoid pressure. Some of them are also publicly saying that we've had our daughters done, but in reality, they haven't had them done. So again, there is change happening in the community, but we wouldn't really know because it's not okay to publicly admit in community settings that your daughter hasn't gone through FGM. And a lot of women, some are now starting to tell us that actually, I've been saying for so long that my daughter has actually gone through FGM, but in reality, she hasn't. In fact, there was one girl who actually went to the hospital because she wanted to be opened and was told that you actually don't have FGM. And she said, but her mother had told her all along that she had FGM. So again, it's quite interesting what's happening. And these are some of the experiences from the research. And I really love this one. She said during her pregnancy, one midwife who looked at her knew about FGM, but when the time came and she saw a new midwife, said she started to scream and said, oh my God, she even pressed the alarm.
And you can imagine the woman who was in a dilemma. There was another one who actually said that the doctor asked her in time of delivery, what happened to you? Did you have an accident down there? And she said, no, I didn't have an accident. Then she went through talking about her FGM. And the doctor was so traumatized that he started to cry, and the woman had to sort of console the doctor. And this was a woman in labor. And when a woman talk about the experiences, it's really interesting. But what's happening is that it really changed the dynamics. And after the research, the women were very, they were so empowered and said, wow, this is the information that we are getting from the field. We know the women who are at risk, and we want to take action. So as part of wanting to take action, we decided that some of the work we could do would be to support the women in engaging more proactive community outreach work. And so the intervention was very much based on the Women's Health and Leadership Program, which we did in Bristol, Birmingham, and in London. The Bristol program, I must say, has been so proactive that now the women have become spokespersons. And when they have statutory training for professionals, women are called in from the group that we're working with to go and speak to the statutory professionals around FGM and what they require from them. So it's really helping to bridge the gap between statutory agencies and communities. Now that work is actually being funded by the Primary Care Trust. We also have an innovative Come and Dance program where we actually do a session on dancing, sometimes belly dancing. And in the process, we also, look at food and talk about FGM. So sometimes we have to do things which are different. And then we have the drop-in service as well. We have our youth program, and the youth program is Young People Speak Out. It's in the 3rd year in London, Middlesbrough, and in Rochdale. We have a youth advisory council, and we have a youth leadership and peer mentoring program. And the whole idea is to support people, to signpost them for services, to also start enabling the young people to understand, because sometimes young people in particular do take a long time to make a decision around services. And often you have to work with them and engage them before they make that decision around services. And a lot of times they don't really have any support in doing that. We started some youth-based work in schools, and in particularly development of resources, and I'll share one of the resources. Our Health Advocates program, the modules that we use, we have the introductory section, we have a session on sexual and reproductive health, and also address FGM. Another module is called Speak Easy, and Speak Easy was actually developed by the FPA of UK, and really talks about speaking easy on some of these taboo subjects. So it's on sex, sexuality, relationships, but also helping women themselves to speak to their children about some of these sexual matters. And it's amazing how a lot of the women said even, speaking to, the young people at very early age about sexual matters, they didn't have the language. So Speak Easy has been very good. And we sort of supported some of the women in Bristol to go for the training. I think it's also a 13-module training. And as a result of that, we're now working with them as facilitators to reach out to other women. We also have a session on safeguarding and intergenerational dynamics, and then communication and leadership and outreach. Some of the learning outcomes for the leadership is better understanding of how change happens, and particularly around women's role as leaders, practical leadership and outreach skills, increased confidence, particularly to talk about their issues, and to enable women to have more social networks at the community level. Engaging men has been a very central part of this program, and this is a response from a young Somali boy. So the first time I came to the training, I didn't want to talk about it. I just wanted to listen, but when I found out the information, I was more confident to go out there. And so how do we ensure that we give men, particularly young men, the tools to be able to talk about it? Some of the things we found in the research with young people, again, they are not a homogeneous group. And so coming from different countries and different social contexts, they don't see themselves as homogeneous. They didn't see FGM as abuse. A lot of them felt FGM was normal. Some had inherited quite a lot of their views, again, from their families. Some said, I was disgracing Somalis for talking about stuff like this. Another said, we didn't know there were different types of FGM. and we had only heard about Sunnah. And again, there was a lot of talk around Sunnah. And it was very interesting how some of the women were saying that we're no longer doing FGM, but we're doing Sunnah. So Sunnah is not FGM. So the language, again, is changing. And then the first time I came to the training, I didn't want to talk about, so there's a lot of things that we need to look at. Engaging young people is so central, and I think that's one of the things that comes out over and over again. This is our Young People Speak Out program, very dynamic young people. And we have a diaspora youth internship program to get people from the diaspora, particularly to engage them in volunteering, and a lot of times to ensure that we get that kind of spirit, but also to give them some skills. Supporting young people as advocates, and also to do some awareness raising. And I will share the materials. In terms of sharing our lessons, we feel that terminology is still very challenging. I mean, over here, there is FGC, there is FGM, there is circumcision. We do have a challenge in terms of even terminologies. Our young people don't even like the word cutting, because they said cutting for them is it gives them, more horrific things about something being cut. So they don't even like cutting. So it's quite interesting how people see that cutting is more neutral. In reality, it's not. And again, we also have that sometimes women say that you ask them the question, are you open or are you closed? There was a research that was done, and some of the women said they really didn't like the word, are you open? Because for them, again, it gives a very bad connotation of women being loose. So, I mean, we need to realize that we cannot win in terms of terminologies. So that's why with Forward, we stick to FGM. Change is happening, but stigma is still very strong. And we need to address other needs of women. It's been said over and over again. And a lot of them don't see FGM as an issue. A lot of these issues, we've talked about it. But I think one of the things that's really missing is supporting the needs of young people, and young women in particular. And over again, we don't really see these programs targeting young women and working with religious leaders. So finally, before I go to my clip, I like this, that violence against women is not something which needs to be inoculated against, but rather it should be embedded in long-standing attitudes, practices, and relational structures. Interventions will only contribute to the elimination of violence if they are part of a planned, coherent, and coordinated prevention program. And I think we need to put our energies into it and making it happen.